this workshop is basically on insulin, and we are going to highlight the insulin injection techniques. We are not going to highlight the techniques, but what are the common mistakes our people commit during the insulin injection. We have got a panelist, Dr. Palani Kumaran from Madurai Medical College, and Dr. Balaji from Kumbakonam, Prakash from Salem Medical College. All these three legends in diabetology. They are very much interested in disseminating the knowledge. They have been doing it for so many years. Happy to welcome, happy to part of this wonderful workshop. Yeah, the common mistakes in the insulin injection. Many people, they make at least one injection mistake, and most of our patients, they apply too much injection force. That is a cause for that mistakes. And we want to highlight one important point. Our patients, whether they use vials and syringes or pen devices, they commit lot of mistakes. Those mistakes which lead to the likelihood of development of the serious adverse events, including hypoglycemia and uncontrolled HbA1c. And many patients, because of the wrong techniques, they develop pain, and the patient, they land up in the hypoglycemia, glycemic variability. When they develop pain, when they develop hypoglycemia, patient, they used to discontinue the insulin therapy. You will not get the treatment adherence or compliance. So we have to use the right insulin injection technique, and patient should know what is a site selection, how to rotate the site, everything. Then only they can achieve the optimized insulin therapy, achieve the good glycemic control, and we can prevent the complications. Now, the time is limited to us. The next, Dr. Palani Kumaran and Prakash, they are going to highlight the classification of insulin and conventional insulins, analog insulin regimens. They take some 10 to 12 minutes. Then we can go to the common mistakes.
Good morning, one and all. At the outset, I thank the organizing committee for giving us this opportunity. I thank our moderator, Dr. Muralidharan, who is a very busy diabetologist in Dendukal, unable to even to attend our calls. Next, I have a happy with Dr. Balaji and Dr. Palani Kumaran. First of all, we want to highlight what are the different types of insulin as a duologue between me and Dr. Palani Kumaran. So first, we start with insulin. Insulin was discovered in the year 1921 and almost 100 years gone. And initially, it was on slaughtering animals, because animal insulin at that time, then it changed to genetic engineering technique insulin. It's called human insulin. Our Professor Hariharan sir used to say, it is not human insulin, it is humanoid insulin. So it was made not from humans, it is from genetic engineering technique. And the development of insulin is day by day increasing. Every year there is a launch of new vehicle, a new insulin. So similarly, we like to start with discussion. Dr. Palani Kumaran, who is my colleague, is working as assistant professor in medicine at Madurai Medical College. And Dr. Palani Kumaran, tell me the classification of insulin.
Thank you, Prakash, for asking this the basic question. And everybody knows that. So we can classify insulin according to the mode of action, actually duration of action. So we know that we do have different, two main classes. One is our conventional human insulins, and the recent one we do have our modern insulin, otherwise called insulin analogs. So this conventional, under conventional insulins, we do have three types according to the duration of action. So short-acting insulin, otherwise called regular insulin, simply we can say it as R. In brand name, any insulin with R, we can brand them as they are short-acting insulin. And the next one will be intermediate-acting insulin. They are the only intermediate-acting available is the NPH, that is neutral protamine hedged on. And simply we can name it as N. Any insulin vial with N, it is an NPH, it's an intermediate-acting insulin. And the next one will be the combination of short-acting plus intermediate at a fixed proportion. So pre-mixed human insulins. So it can be either 30/70 or 50/50. The first component will be R and the second component will be N. Coming to the insulin analogs, we do have rapid acting insulin analogs such as Aspart, Lispro and Glulysin, and long acting analogs like Glargine, Detimer, ultra long acting Degludec and Glargine U300, and premixed analogs such as proteminated Aspart and proteminated Lispro, and premixed co-formulations, that is a combination of Degludec plus Aspart, that is Idacasp. So these are all the insulins available in the market. So we have to play our insulin management with these type of insulins. Now over to Prakash. So what are the difference between the comparison of conventional and analog insulins, Prakash, please?
See, conventional insulin, we have short-acting insulin and intermediate-acting insulin, which we have been used for many years. Now we have designer insulin, modern insulin. It's called insulin analogs. The conventional insulin is, we have short-acting insulin, which has to be given half an hour before food. Why half an hour before food? Because it is in hexameric form. It has to get converted to monomer, then only it acts. So it takes a lag time of 30 to 45 minutes. So we can't give just before food. That is the disadvantage of conventional short-acting insulin. Now we have short-acting insulin analog, wherein it is already in monomeric form. It can be given just before food or immediately after food. So this is the advantage of short-acting insulin conventional and the present short-acting insulin analog. And then it has got a shorter duration of action. The conventional insulin has a duration of action of 8 to 12 hours. So hypoglycemia risk are more with conventional insulin, but with modern short-acting insulin analog, the duration of action is only 4 hours. For example, if we take food by 8 o'clock, we get hungry by 12 o'clock. So, whereas the conventional insulin will lag for a longer period of time, resulting in hypoglycemic risk. Whereas with modern analogs, that risk is not there because the duration of action is only for 4 hours. And we have different mixtures of conventional insulin as well as insulin analogs. We have regular insulin with intermediate acting insulin combination, and we have similarly short acting insulin analog when combined with long acting. So we have all sorts of mixtures with both modern and conventional insulin. So long acting insulin analogs, we have Detimer, Glargine and Degludec. What is the advantage of old intermediate acting insulin, long acting analog is the good basal insulin should have 24 hours duration of action. So the conventional insulin has only 12 to 14 hours. So there is and another advantage of long acting analogs is there is peak-like plateau-like action. So there is less risk of hypoglycemia. So these are all the advantage of modern insulin and conventional insulin, and it mimics physiological insulin secretion, better time action profile, predictable action, superior postprandial reduction, more safety, less weight gain, and mealtime flexibility will be better with modern insulin, and it's convenient use both in vials as well as in pens. Next, I invite Dr. Palnikumaran to talk on what are the insulin regimens that has to be followed in the management of diabetes.
So regarding insulin regimen, we should know some basic regimes which are commonly practically useful for our patients. The most common will be the basal only insulin regime, and this is ideally suitable for type 2 diabetic as a outpatient settings. So whenever a type 2 diabetic patient with the maximum OHA has gone for beta cell failure, so recurring insulinization, so in that case you can, along with the OAD, you can add this basal insulin. So this will cover, it can be given, if it is going to be NPH, it can be given in the night, or if it is going to be the true basal, that is insulin analog, it can be given even in the morning. Next. So next regime will be bolus insulin regimes. So this is, giving a bolus, that is short-acting insulin with each meal, before each meal, so that it will be covering the postprandial blood sugar surge. So this regime can be used at times, but it's not commonly used. Isolated bolus we are not commonly using. And next one is the basal plus. So by having a basal insulin, that is a long-acting or NPH insulin, you can add a prandial insulin, that is bolus in short-acting insulin, whenever a particular meal, the particular meal is causing an increased postprandial surge. So suppose morning breakfast alone is high, you can have a basal, along with you can add a prandial insulin in the morning time. That's called basal plus regime. And next regime will be basal bolus regime, and this is the ideal regime for type 1 diabetes and ideal regime for any type 2